Hi, this is Aaron again. We were just talking not that long ago. We were talking about cough in the early clinical experience, and we went through some of the questions or issues that you might be interested in if you see a patient with cough. And we're now going to talk about we're going to talk about cough in the early clinical experience again, but we are going to talk about that in terms of timing. So we're going to put in a timeline here. It's going to be in weeks. And we'll just draw a little timeline here, and obviously we start with 0, and then 1, 2, 3, 4, 5, 6, 7, 8, and so on. Now, pretty much everybody, well, it depends on who you read, but this section in here is acute. This is an acute cough. And in the acute cough, you might think about this is where you would find respiratory infections. And that's where those might be. And also aspiration. Now, this is particularly, it can happen to anybody, but we're thinking about kids here. And there are two things that happen. You can have the acute one, so they inhale something, a toy or food or something like that. But there's also, these kids can actually have chronic aspiration, especially little kids who swallowing muscles aren't working quite well, and they can be chronically aspirating small amounts of food. That actually, as you might imagine, shows up later, but we're talking about aspiration. We'll put that right up there. Now there's a persistent or subacute, depending on who you read. So in this section, this is where there might be post-viral. And there, we see a lot of this in a clinic. People who were sick and then they come in with the cough. But there's another group that I'm going to talk about, that I want to make sure we talk about, that's really important because it's becoming more prevalent or at least more noticed. That's Bordetella pertussis. Sometimes it's often just called pertussis. That's probably in part because this tussis part, that's Latin for cough. You'll see that sometimes it's in, the name will be in medications, but anyway, tussis means cough, and pertussis is this bacteria that causes whooping cough. There's still a whooping cough, but in adults, the cough is it's caused by a narrowing, the whoop is caused by a narrowing in the trachea and caused by the inflammation. You get inflammation in the trachea area and everything gets narrow, and that causes that whooping sound. In adults, sometimes it's called the 100-day cough. It just goes on and on and on. And it has something to do with the way we vaccinate for pertussis. And we can talk about that kind of thing later. And then down here, when you get past 8, pretty much everybody agrees that's chronic. So in the chronic group, there are lots of things that can happen there. It's a very long group. But you can imagine there are inflammatory causes. And inflammatory can be not just, usually we mean something other than an infection. But it could be irritants or irritation from something that people are chronically exposed to. So maybe the chronic bronchitis of smoking would show up there. It can be infections that are chronic. So that might be where tuberculosis or something like that would appear, or some other slow, persistent infection. Neoplasm. Now that's a growth. Neoplasm is new plasm, so it is a growth. That's a new, and then plasm is tissue, so this is a growth. Now, whenever doctors think about this, usually we're worried about cancer, but there are non-cancerous growths that can lead to cough. I think often when patients hear neoplasm or people who aren't in healthcare, they get a little confused. And there are cardiovascular causes. Now, there are others too, and I think any pulmonologist is going to argue with me that this is not a long enough list, but I think for new medical students who are working with patients with coughs, this is probably reasonably okay. In the shorthand of all of this, anybody who's, this is one of those places that people argue, but sort of in this section, somewhere from subacute, certainly, I'll try to make this probability maybe. Let me erase this. Here, I'll erase my little green line. And we're going to try to make a probability line here about whether or not you should get a chest x-ray. And I think most people would say absolutely down here. Got to get a chest x-ray. Then maybe a little bit less as you head back somewhere in here. And there would certainly be times when you'd feel like, oh, I have to get one back here because I'm worried about something. And, for the kid who has a Lego, you would probably want to get an x-ray. But almost certainly down here. Now, there are a group, if we think about that, what happens if the chest x-ray is normal? So normal chest x-ray. And we're going to talk about abnormal chest x-rays another time. But there are a few things I want you to think about here. So one is asthma. Not everything that wheezes is asthma. And asthma doesn't always wheeze. Sometimes people get a cough. It's an inflammatory condition. Here, this is one of those inflammatory conditions. And it can cause a cough by irritation of stimulation of receptors in many places. Heartburn, actually, which is gastroesophageal reflux disease, can cause it. And then the Michigan favorite, post-nasal drip. Oops, not drup, drip. So, for those of you who remember some of the other ones, this is a classic Michigan condition. There we go. Oh, Michigan right there. And then there are some medications, and mainly the ACE inhibitors, which are a blood pressure medicine. And those end with prill, and there's probably a whole little piece to be done just on how those cause cough, but there we go. And we'll see you next time.